Good day to all of you. My name is Sam Vaknin, and I'm the author of Malignant Self-Love, Narcissism Revisited, as well as a professor of psychology in Southern Federal University in Rostov-on-Don, the Russian Federation, and in the Center for Advanced Studies, CIAS. I've spent the past 7 years developing a new treatment modality for narcissistic personality disorder. I dubbed it cold therapy. The past 22 years I dedicated to the study of pathological secondary narcissism, narcissistic defenses, and in the most extreme cases, malignant narcissism and narcissistic personality disorder, the full-fledged disorder of the spectrum. And I reached a conclusion that there are several misconceptions about pathological narcissism. It is presented as a regression to an earlier childhood developmental phase, or a psychological defense, or an organizing principle or a schema, or, in the more comprehensive form, as a personality disorder. And it may well be all these four, but not only these four. I think a much better way of looking and considering pathological narcissism is as a post-traumatic condition. Pathological narcissism is elicited and provoked in a child. It starts at the age of 3 or 4 during the formative years, in an abusive household, where the child's boundaries are not recognized and individuation and separation are prevented by a capricious, narcissistic, or even malicious parent. So, this traumatic experience gives rise to a whole array, a whole amalgam of defenses, which we call pathological narcissism. It therefore behooves us to regard pathological narcissism as a post-traumatic condition. The second thing that I notice is that when narcissistic patients, when narcissists finally attend therapy, having hit rock bottom, they are treated as adults. Techniques borrowed from adult psychotherapies are applied to the treatment of the narcissist. But narcissism is not an adult disorder. It is an attachment dysfunction, and it is coupled with arrested development. It therefore should be amenable to techniques borrowed from child psychology and from trauma therapy. In other words, I regard pathological narcissism as less of a disorder of the self and more of an interpersonal disorder. Indeed, as Hazen and McFarland wrote in 2010, when alarmed, the child seeks proximity to a caregiver, a safe base, but proximity to frightening caregivers increases the alarm. And I think the child attaches to an imaginary caregiver in this case, and this is the false self. The false self is a godlike concoction. The false self is everything the child is not. The child is helpless. The false self is omnipotent. The child doesn't know what's going to happen next. The false self is omniscient. The child is perceived as a bad, worthless object by the parent and introjects this perception. The false self is perfect and brilliant. In a way, narcissism is a private religion, with the false self as the deity worshipped by the narcissist. And so the child remains fixated. And when a narcissist comes to therapy, he is 9 years old, sometimes younger. There's no point in applying adult techniques. And this child is heavily traumatized. It's a child with no boundaries, a child with no organization of the personality. It's a severe post-traumatic condition, complex PTSD. And so cold therapy adopted a completely different approach to pathological narcissism, as I said, not regarding it as a personality problem or a character problem, but as an interpersonal issue. And so what cold therapy seeks to do, following in the footsteps of Fria and Kozak in 1985, what it seeks to do is to re-traumatize the patient. The idea is that if the patient goes through the same trauma again, if he's re-traumatized, then this should be helpful in resolving the conflicts, in achieving closure, in countering avoidance, helplessness, and depression. Of course, the re-traumatization is both controlled and tiered. There is a process of triggering, trauma stimulation, stressing, but the environment is a non-holding environment. It's absolutely hostile. We are trying in cold therapy to generate a facsimile of the environment of the primary or originating trauma. And there's no way to generate such a facsimile in a holding setting. If the therapist is empathic, compassionate, genuinely emotional, concerned with the patient, that is not a replica of the abusive parent, and the re-traumatization process will fail. The therapist needs to emulate the abusive parent, and that is why we encourage, actually, transference in cold therapy. The idea is that as the adult patient emerges from the re-traumatization process alive, as he survives the re-traumatization, as he successfully copes with it, the patient's maladaptive narcissism, his cognitions, his beliefs, his emotions, the schemas, if you wish, all these will be rendered redundant. The patient will no longer need his pathological narcissism to cope. Pathological narcissism starts as an adaptation. It's adaptive in childhood. But the adult patient needs to learn that even if he finds himself in an identical state of trauma, there are other mechanisms to cope. He does not need his narcissism anymore. It's unnecessary. It's obsolete. And as we know from the principle of economy of mental energy, if something is unnecessary and obsolete, it vanishes and fades away. So this is the core concept, the core tenets of cold therapy. Cold therapy reinterprets the narcissist's behaviors and actions in a socially acceptable light. It emulates, it kind of combines cold empathy with emotional resonance tables. But we'll talk about it a bit later. What are the goals of cold therapy? The goals of cold therapy is to process trauma via skilled reliving, foster more adaptive functioning, replace negative with positive coping strategies, integrate distressing materials, thoughts, feelings, and memories in a way which would render them, neutralize them, lead to internal resolution and homeostasis, and aid the growth of skills such as resilience, ego regulation, internal ego regulation, and empathy. Narcissistic supply is thereby rendered unnecessary because the main role of narcissistic supply is the regulation of the sense of self-worth, its stabilization, and the fulfillment of certain ego functions which the narcissist is unable to provide from the inside. At the conclusion of cold therapy, the narcissist's ego construct, so to speak, is perfectly functional. We all know that narcissists are difficult patients. We know that there's a variety of types of narcissists. Overt, classic or grandiose. There's covert, shy, fragile, and vulnerable. Inverted narcissists, somatic, cerebral, etc., etc. We know that narcissism is comorbid very often with other personality disorders, and they're dually diagnosed with eating, mood disorders, substance disorders, and even autism. And there are various treatment modalities that have tried to cope with narcissism, with the core, with the nucleus. Enough to mention various cognitive behavioral and emotive behavioral therapies, schema therapies, EMDR, dynamic therapy, psychoanalysis, gestalt, you name it. They have not been successful. There has been some success modifying behavior. Abrasive behaviors, antisocial behaviors, socially unacceptable behaviors, all these have been modified to allow the narcissist to coexist with other people and to somehow function in various settings, such as the workplace. But this is far from healing. This is far from tackling the core and the nucleus of narcissism. This deals with these techniques, these treatment modalities deal with some presenting symptoms or signs. Indeed, even the process of clinical interview, anamnesis, diagnosis, they are all heavily dependent on self-reporting. Current existing psychological tests, such as the narcissistic personality inventory, are ridiculously premised on the assumption that narcissists will truthfully self-report. And we all know that narcissists are pathological liars, confabulators. So the patient's narcissistic defenses and resistances prevent proper therapeutic lives. They even prevent a proper diagnosis. Psychological tests are useless. And the realistic therapy goals with existing treatment modalities is some form of behavior modification, as I mentioned, reconciling lifestyle and choices with pathological secondary narcissism, and setting an extended time frame, a measurement of outcomes that somehow will create a positive feedback loop. These are very restricted but realistic goals. But they're very restricted, that's the problem. They don't touch the core, as I said, and they are not long-lasting. The rate of remission or relapse is enormous, almost, I would say, universal. And the therapist in these treatment modalities suffers. The therapist suffers idealization and devaluation cycles. There's transference and counter-transference, which is very pernicious. There's vicarious traumatization of the therapist. The therapist's own narcissistic defenses are heavily provoked. Resentment, alienation, burnout, emotional exhaustion, trauma, very common. And finally, there's a lot of cooptation and collusion. The narcissist tries to buy or bribe the therapist, or to victimize the therapist. And so that very often we have situations where there is a shared psychotic disorder somehow emerging, a folie à deux. There's paranoia as a form of narcissism, placing the narcissist at the center of some persecutory delusion in which the therapist plays the role of a persecutor. And cult settings are not uncommon, where the therapist actually admires the narcissist. So it's all very problematic, and I would say, with a sweeping generalization for which I hope to be excused, that all current existing treatment modalities have abysmally failed to deal with pathological narcissism. It's not that cold therapy is devoid of its own problems. For example, it needs to leverage the false self-grandiosity, and that's not always easy. And if the line is crossed, actually it could enhance the narcissist's grandiosity. Grandiosity and fantasy are defense mechanisms, and unhealthy ones, dysfunctional ones, maladaptive ones. So we seek to minimize them, not to maximize them. But cold therapy walks a very fine and thin line, and sometimes actually ends up enhancing fantasy and grandiosity. There's an issue of overcoming psychological defense mechanisms like splitting, projective identification, projection, magical thinking. There's an issue of tackling cognitive deficits, cognitive distortions, thinking errors, fallacies, and failed reality tests. Example is the Dunning-Kruger grandiosity fallacy. And then there's the issue in cold therapy of dealing with the narcissist's victim stance and internal working model. They are challenged heavily in cold therapy, on the one hand, but on the other hand, they are somehow supported and enhanced because the narcissist is really victimized in cold therapy. He's really traumatized. It's not his imagination. His paranoia, in this case, is justified, and so is his victim stance. So how to modify his internal working model when we're actually ending up supporting it? There's also a risk of suicide at the very beginning. The re-traumatization phase can be very dangerous and requires close monitoring. All kinds of grandiose, paranoid, and schizoid automatic thoughts are provoked. And contracting and alliancing are absent, so there's no common goal, no kind of mutual horizon. It's all conflictive. Cold therapy is very adversarial, and we need to manage and contain transference and countertransference very carefully, or it gets out of hand. And of course, the patients who are also on medication, medication's effects and side effects need to be taken into account. Most importantly, I would say that because cold therapy is confrontational, because it fosters knowingly a hostile environment, because it imposes trauma on the narcissist, it fosters persecutory delusions. It creates intentionally paranoia, narcissistic rage, narcissistic shame. And so the aim of cold therapy is to distinguish primary originating traumas from secondary ones and from complex PTSD. So we have tools, proprietary tools, developed in cold therapy, aimed at doing exactly this. And ultimately, we need to merge the patient's comfort zone with the hostile, non-holding, unsafe environment. And this merger, this fusion, lead at the beginning to some kind of repetition compulsion. On the face of it, this sounds bad. Repetition compulsion is not a healthy thing. But it's far preferable to decompensation and acting out. So here you are. I've been honest with you about the disadvantages, shortcomings, shortfalls, and dangers of cold therapy. But experience with several dozens of patients has shown that cold therapy is unusually, I would even say incredibly effective with narcissistic disorders, and to our complete surprise, with major depressive episodes. We are not sure why. Perhaps because pathological narcissism is a form of depression. But that's a topic for another presentation. So, cold therapy currently comes with 25 proprietary techniques. And these techniques are highly unusual in various ways, and even I would say counterintuitive. They are divided to level 1, 2, and 3. On level 1, we have some more basic techniques. And one of them is called erasure. Erasure, again, builds on the work of Fria and Kozak in the 80s. They said that fear memory, the memory of fear, is combined with absent information. So what we do in erasure is suppress expression. We suppress the speech of the patient. Now this runs completely against anything done in any other kind of therapy. In all other kinds of therapy, we try to encourage the patient to share, to cogitate, to associate, to talk, etc., to communicate. But in cold therapy, we actually encourage the patient to shut up. And we do it pretty aggressively. We select a series of keywords, and we then filter for keywords which are heavily associated or describe a primary and original trauma. And these speech suppression techniques are both active. We hush the patient when he tries to use the keywords, or they're also passive. When the patient uses a certain keyword, we ignore it, or we treat it as irrelevant. We underestimate it. So that finally there's a negative reinforcement mechanism which kind of suppresses these keywords. And the idea is that the silences generated by the erasure technique tell us much more about the patient, or as much about the patient, as any form of communication. The silences are structured, but they reflect sentence structure and semiotic and semantic worlds of the patient. So, where the patient has to be silent because he cannot utter a certain keyword, tells us that this silence denotes some connotative field, tells us a lot about the inner world of the patient. So that's an example of a technique. Then what we do, we recover the speech and we interpret the silence together with the patient. We have a look at the patterns of the gaps in the speech, at the distribution, in the context of the gaps, contextual gaps, and then we construct and deconstruct, reconstruct and deconstruct narratives so that the patient gains much deeper understanding of how the traumatic words reflect the structure of the trauma, reflect the infrastructure of the trauma, the cohesive trauma. Another technique we have, and I of course won't be able to go through all the 25, but another technique we have is hypervigilant referencing trauma and abuse are a kind of perpetual narcissistic injury. And obviously they lead to hypervigilance, obsessive compulsive behaviors, rituals, irritability, rage, sensory sensitivity, anxiety, arousal, exhaustion, and scanning constantly for threats and insults, often when there's none. So it's a kind of referential ideation. And so hypervigilant referencing strives to learn from the content of the delusional thinking about the locus of the primary originating trauma. It deconstructs the disparity between emotional and reality states in a highly specific way. Another technique we have is called grandiosity reframing. And it's a bit unusual in that it treats grandiosity not merely as a psychological defense mechanism, but also as a cognitive distortion, extending the work of Dunning-Kruger and their effect. Grandiosity is justified only in as much as it is an adaptation or a survival strategy, but with a narcissist, it is neither. It's not an adaptation because it's maladaptive, and ultimately it leads to the narcissist's downfall and implosion. It's a self-destructive strategy. Grandiosity provides capabilities to overcome traumas, that's true, and in this sense it's a kind of skill. And it results in winning in various settings. But what we do, we leverage the narcissist's grandiosity in order to get rid of it. For example, we tell the patient, when you are grandiose, you are not acting optimally or efficiently. You are not perfect. So we use grandiosity against itself. If you tell the patient when you are grandiose, you're not perfect, you're actually making a statement about grandiosity. Similar to, this is very similar to the way we strengthen the host personality in dissociative identity disorder. Another technique, which of course is borrowed, is the technique of guided imagery. But again, it's proprietary in the sense that we have modified it very considerably, and we call it imaginal technique. So what we do is we encourage the patient to catastrophize, actually. We leverage catastrophizing. We ask the patient to imagine the worst, and in a controlled way, but to imagine the worst and then to live through the worst. We control the patient's malignant optimism. We imagine the fantastic. We have something called midlink, and that is to locate the middle ground and to render the adult side of the patient the winner by meeting a strict, rigorous reality test. We have controlled depersonalization. When we deconstruct the false self, the patient remains basically exposed, naked, vulnerable. And so what we do, we encourage the patient to depersonalize. Because if the patient does not depersonalize and derealize, the patient is in such pain and hurt that it could lead to suicide. Depersonalization and derealization, which are encouraged in this phase, are intended to protect the patient against the hurt and the pain that the false self used to cater to, used to block out. But ultimately, we validate reality. We acknowledge the patient's transference and the client's own language. We echo it, we mirror the patient, and we acknowledge his state of mind. But we compare it to reality in such a way that reality intrudes and replaces all these. Another technique we have is called negative iteration. In negative iteration, what we do is reframe situations and events as traumas. We design special coping strategies, winning strategies, and defenses for various situations and events instead of catastrophizing. We observe, we hold, we freeze, we use a lot of techniques from cognitive processing therapy. And we try to engender personal safety, trust, a dynamic of power control which is not out of control. We try to foster esteem or self-esteem, intimacy, by reconsidering or reframing negative thoughts about self, others, and the world and the environment exactly as is done in many, many types of cognitive behavioral therapy. We encourage assertiveness, communication, social support, but we do all this by foisting on the patient and encouraging the patient to develop a kind of repetition compulsion. This repetition compulsion is then brought to awareness, it is mastered, and it is used, its power, its energy is used to obtain different outcomes. It actually leads to resolution and reconciliation. So, one of the most powerful techniques we have, and we use utterly independently of cold therapy with patients who don't undergo cold therapy, is the happiness map. Happiness map is a kind of happiness space. And what we do, we ask the patient to list everything that makes her happy, and then we narrow it down by finding common denominators. We reduce the number of happiness-inducing factors by finding common denominators. We drill down, in a way. We reduce. And so, and we do this in the face of reactivity and denial. There's a lot of resistance to the happiness map. Because the happiness map yields counterintuitive results. You may think that your children make you happy, but by the time you are finished with the happiness map, you discover that it's not your children at all. You may think that some activity makes you happy, but then you discover that actually it's not the activity, but it's excelling at the activity. And so, what we try to do is we try to create new intuition in you, new ways of thinking about your happiness. Of course, we use mirroring in cold therapy. The patient or the client is requested to play the devil's advocate via dialectic, Hegelian dialectic. Thesis, which is the abuse and the trauma, antithesis, which is not abuse, not trauma, and then synthesis. Trauma is not an objective scientific fact or event, but a subjective reaction to an objective or scientific fact or event. Traumas are reactions, not reality. They are a subjective form of exegesis, of interpretation. They are reactive, as I said. There are many other techniques. There's escalation, where we construct a scenario, what could have been worse, what could have gone even more wrong. There is role play, where the patient is encouraged to be the abuser. There is other scoring, where the patient is actually encouraged to develop empathy by placing herself or himself inside the mind of meaningful or significant others in his or her life, in ever more complex nesting algorithms. So I'm thinking about the other, then I'm thinking about how I'm thinking about the other, then I'm thinking about how the other is thinking that I'm thinking about the other, etc., etc., etc. So it's ever-evolving tree, nested tree, until the complexity is such that it breaks down defenses and absolutely forces the client to become someone else and develop a form of empathy. Rudimentary, but there. And then we have assimilative confabulation, where we encourage the patient to identify gaps in his memory, dissociative gaps, and ask himself, why did he repress these memories? And that's very similar to some psychoanalytic techniques in psychoanalysis, psychoanalytic psychology. And where the gaps are unbridgeable, where the memory is gone, totally gone, we don't want to have an abreaction. In that case, we construct confabulations, and that's why it's called assimilative confabulation, this technique. We construct confabulations to bridge the gaps, and then we ask the patient to rank the plausibility of such confabulation, and we demand that the patient owns the confabulations and assimilates them. And then, once the patient tries to assimilate the confabulation, we monitor, we observe the reaction. Does he react with ego dystony, unease, or does he react with ego syntony, happiness? Ego dystony teaches us that there is some discrepancy or discontinuity or disjointedness in the patient. And ego syntony, of course, indicates congruence, narrative coherence. So we assemble gradually Lego-like, a healthy core, narratives about functioning and happiness that can be assimilated by the patient, can be accepted. And in one thing we do, for example, in this therapy, we share our therapy notes with the patient. The process is completely transparent. The patient is a partner, not an ally like in a classic therapeutic alliance, but a full-scale, full-fledged partner with equal status to the therapist. Some of the techniques, we're talking about the phase after re-traumatization. Very important technique is reparenting. And that's why we encourage transference, and we actually foster, engender with a kind of shared psychotic disorder, a kind of folie à deux. At the beginning, we encourage this so that the patient can feel that we are his abusive parents, and shift the potential locus of trauma from himself to the therapist. And the therapist is the one who owns the bad object. The therapist owns the pain, owns the trauma and the hurt. Splitting is encouraged, even leveraged, and the patient now ends up owning only a good object. When this good object is introjected, the patient can begin to feel good. Projective identification and introjective identification are very powerful tools. The therapist picks up and contains, via projective identification, what the patient cannot think about, the unthought known. We have also emotional re-regulation. We encourage a patient to, instead of externalizing, to internalize. We encourage a patient to shift from grievance to task orientation, to avoid rumination. We encourage a patient to move from counter-dependence, defiance, to codependence in some respects. We encourage a patient to move from social withdrawal to social functioning. And from child psychology, we borrow techniques like emotional intensity control, behavioral control, determination, interpretational modes of emotional cues, including his own cues, interpretation of social cues, avoidance and regression balancing, focusing on the positive, attention and focus control, impulse control, modeling and not demanding, desired behavior, freedom versus constraint and self-regulation, no overstimulation, no excessive frustration, identifying and countering discriminating thoughts and emotions, and moving from internal construction to external representation. All these, I must emphasize, are after the initial stage of re-traumatizing. In the initial state of re-traumatization, the therapist is the abusive parent and the patient is the child. Emerging from the re-traumatization phase, the therapist is the bad parent holding the bad object, and the patient is rendered a good adult, identified with a good object. Cold therapy is a highly unusual treatment modality in that it actually makes use of all the artifacts in other therapies which are considered negative and to be avoided. And in that it does not coddle or cuddle the patient or the client. On the contrary, it's adversarial. It's much more like a court of law than a classic therapy setting. But through this conflict, through this repetition compulsion, a new adult emerges with firm boundaries, with a healthy core, and with absolutely no need for narcissistic supply or any other forms of external ego function regulation. A healthy, stable sense of self-worth, totally regulated in all environments and all settings. And isn't this the very definition of a healthy, normal individual? Socially functional and happy in his interpersonal relations. This is the aim of cold therapy. Thank you very much for listening.